Hello students, and we're going to go over several chest x-ray imaging examples today and go over some of the pathologies associated with them. Let's get started. Normally, this is what your lung and bronchi should look like. On x-ray, this should be invisible, particularly the bronchi. Now, on chest x-ray, normal chest x-ray in particular, you will see some of the hilar vascularity, such as the pulmonary arteries and vessels around the perihilar region. But for the most part, the majority of the bronchi should be invisible in a normal, healthy lung. Now, with disease pathology, we have uh, we have the capability of seeing these things due to plaques or calcification buildups or certain fluid densities that could accumulate within the normal lung parenchyma and bronchi. This is a schematic here of a chest radiograph to help guide you through your journey of evaluating chest x-rays. Um, you can refer to this as needed. It's in more a simplistic manner, but it's also helpful as well to guide you as far as where things may be located. Now, I know I explained to you in the announcement that in order for you to understand abnormal, you will need to get a thorough understanding of normal. I recommend that you go over slides in our PowerPoints that have labels on them, such as this one. This one has layers located such as the aortic knob or aortic arch. You're able to see the trachea here in full form. Here's a carina right here. We can outline that for you. So you can help locate that. Here's some of the hilar vasculature that we see. Um, right atrium is over here. And we have the paraspinal line here where the thoracic spine is seen behind the heart. Okay, so that is a good picture there. Left ventricle is located over here in this region, and then we have our pulmonary trunk here as well. Okay, good nice border there. Now we discuss the densities quite often in class with air, water, bone, and metal. Please keep these densities in mind when you are evaluating your chest x-rays. Um, as a thorough understanding of the different types of densities will help guide you in determining pathology on chest x-ray. Here we have a normal chest x-ray with the left and right main bronchi noted for you here. The carina is right in the center. This is a good baseline chest x-ray to compare the other ones that are on this presentation and in your PowerPoints that present with certain pathologies. Um, Here we have the trachea, the shadow that it forms. Here's a carina. We have the cardiac border here with the left ventricle and the right atrium. Your left and right hemodiaphragm with the costophrenic angles that are sharp here. This is black as it should be because the lungs are mostly filled with air. But yeah, this is what you should initially start doing when you get the chest x-ray. Start locating the trachea, the carina, left and right mainstem bronchi, the hilar vasculature, cardiac borders, making sure you can see certain densities. And if you understand normal, you'll most definitely be able to understand abnormal. Uh, Here, for example, if we compare the previous x-ray to this one, this looks like a large amount of white, particularly fluid density. This is a particular uh, left lower lobe and some of the left middle lobe, pulmonary edema or a pleural effusion as well. You can see the excellent line of demarcation here. I've circled this for you, but this is completely obliterating the visualization of the left lung field, both at the middle lobe and lower lobe. It also obliterates the cardiac border along the left ventricle as well as the left hemidiaphragm region, and you can see that the left costophrenic angle is completely absent in this situation. We still have some remnants of air in the lung in the left upper lobe, but this is a clear-cut example of a liquid or water density that is demonstrated as a space-occupying lesion and completely obliterating all the cardiac borders, hemidiaphragm borders, and costophrenic angles, which is consistent with some sort of fluid hemodynamic insult to the lungs and chest cavity. Here we have the left and right hilum highlighted for you. Now this is a normal chest x-ray as well. Here we have what we call the gastric bubble, which should always be there on the left hemidiaphragm region. Notice your normal pulmonary vasculature here as well as here. We have your trachea down here and your carina right down in the center here. Here is a good example of what you should be looking at when you gaze upon your eyes of a chest x-ray. Here's some more detailed anatomy of the hilar region with actual labels to the particular veins and arteries found within the hilum, as well as left pulmonary artery right here in this region as well. So this is a more in-depth approach to looking at the hilar anatomy. Here is the carina. You may have to zoom in on some of these to get a better idea of where you're positioned as you evaluate the chest x-rays. This image also has labels to guide you in chest x-ray evaluation. Notice here that the costophrenic angles here are very sharp, as you can see here, as well as on the left side as well. The gastric bubble is here. Now the right hemidiaphragm is going to be slightly higher than the left due to the fact that the liver is directly inferior to it. You can trace the border here of the aortic arch and your left ventricle. The heart will sit directly on the superior aspect of the diaphragm. But you should be able to see clear, distinct borders between the heart and the lung parenchyma region, as are differences here with the air and fluid densities. Over here we have the right atrium, the right cardiac border as well. So this is how you're going to get good at these chest x-ray evaluations. The more normal you see with these labels, you'll be able to get an idea of where everything is located. And it's a good way to quiz yourself, so that way you can orient yourself before you start making decisions of what you see or don't see on a chest x-ray. This is another one as well. This one has the cardiac and aortic borders outlined for you here, costophrenic angles as well. We have regions as well that are black, which are filled with air. The hilar vasculature is right here in the perihilar region. But these are helpful to get you a clear-cut understanding of normal when you start to evaluate abnormal. Now, the PA view, which you can see here on our left, has this patient laying directly on the region where the film is located. The most important structures that are in the chest, such as the heart and the great vessels, they're located anteriorly. So this is why we would like to have the film as close as possible to the anterior chest. So when we take a chest x-ray, we like to have the patient's anterior chest region directly up against the film to get a better image and to help decipher any abnormalities that may be present. Now, in the lateral chest x-ray, we place the patient in profile view. So this patient has her left side against the film. So the x-ray will take a picture of her left lateral region. So when we compare the two types of positioning with the chest X-ray, PA versus AP, notice that in the PA view, the X-ray beam is behind the patient. So the anterior part of the chest is directly on the film, and the beam is directly behind the patient. Uh, Not directly behind, but as you can see there, it's about 72 inches from the patient. But this is enough distance to create an excellent shot for evaluation of the structures within the chest cavity. Um, so as a result of this positioning, any any view that has the X-ray beam pointing uh, towards the patient. So for example, here we have the term posterior anterior view. That posterior, that first letter P, is going to signify where the X-ray beam is located. So the X-ray beam is posterior, so posterior anterior, so the anterior structures will have a greater visibility because they're up against the film, and vice versa. So the X-ray tube in the AP view is anterior towards the patient, and the patient is laying on the film. This is reserved mainly for patients who are too sick to stand or are bedridden due to lower extremity fractures or decubitus ulcers. This is considered a lower quality view because it causes the structures in the anterior part of the chest to become magnified and not as sharp as when compared to the PA view. Okay. Uh, so the closer an object is to the film, the sharper the borders are. So in this situation here, we have the PA view. Here we can see clearly distinct sharp cardiac borders. We're able to see everything very clearly here. Um, but in the AP view, the heart is magnified to a great degree, as well as the hemodiaphragm regions, and we don't get a great quality image of the lungs here, due to the fact that the patient is laying supine and the X-ray beam is pointing directly anterior. So we do have to, in some situations of medicine, work with what we got. And if there's a patient who is completely bedridden or unable to walk for any type of reason, we're going to have to just manage with the AP view in this type of setting. The lateral view is taking the patient in profile. They are ordered routinely, like I mentioned in class. We just don't order one view. We order at least two, sometimes three, sometimes four views to help us localize any lesions that may be hidden within the compartmental regions of the anatomical structures of the chest wall. But yeah, this is done in the profile view. So if we see something anteriorly, we can compare it and locate it on the lateral view as well. This helps us determine if lesions are located within these anatomical blind spots that we discussed in class, because anteriorly could be hidden by a structure such as the heart or some sort of fluid density that is compromising the view, and that will lead to us looking at the lateral view to help us identify and locate the structure that is sinister. So here we can see that this PA view here, you can see that there is a significant mediastinal shift. The trachea is deviated towards the right. We have complete obliteration of the cardiac borders, both on the right and left. They are coalescing into that left hemodiaphragm. Airspace is being taken up by fluid density here, as we can see. So sometimes we have to determine between if it's fluid or if it's pus or some sort of viscous fluid that is causing issues. So we place him in the left lateral decubitus position here in this situation, since the density was found on the left region of the chest. You can notice that gravity, when you're upright, will tend to pull liquids in all structures such as swelling, blood, anything distally towards the lower extremity. When you lay it on your sides, it should even out and fill up the rest of the lung cavity, you have this clear line of demarcation here showing we call an air fluid level. As you can see here, there's a little bit of air left here in the left upper lobe, and then the rest is fluid. So this is an example of an air fluid level seen primarily with the with the lateral decubitus view to help us identify between fluid versus purulent substance that is found within the lungs. This is another example here. So decubitus is a fancy word for you're basically lying down. So it's a PA view with the patient lying on their side. So it's very helpful to help us differentiate between different types of fluid or viscous substances found within the pleural space. So as I mentioned earlier, fluid tends to collect more at the base of the lungs due to gravity. So if you do suspect a pleural effusion or see findings consistent with what you're looking at now, go ahead and order a lateral decubitus view to confirm if that fluid is going to present itself in this situation where it completely fills up the rest of the upper lungs, and you have a clear line of demarcation here with an air fluid line located here. So that is the importance of ordering a decubitus view when you have evidence of a pleural effusion or pulmonary edema on the PA view of the chest x-ray. So what we're looking at here is another set of normal x-rays, chest x-rays in particular. So this is the frontal view of the normal chest x-rays you can see here. This particular image has your trachea, carina, and right and left main bronchi outlined for you. So the more you look at these areas that are, these images that are labeled for you, and then you go ahead and compare it to one that isn't labeled, such as this one on our right, you're going to be better able to visualize these labeled structures in your mind, and then when you present it with a chest x-ray like this one that's not labeled, you're going to be better able to understand where things are located. So as you can see here, we have the trachea, we have the right and left main bronchi, and then we have the pulmonary vasculature, which is basically this stuff here. You can actually see it. It's a little bit of a less bright white. That's because there's blood in there. Blood is a fluid density. The lower branches here, as you can see, are larger. That is a result, as I mentioned earlier, due to gravity. And as always, keep this in mind at all times, that your bronchi should be invisible on a normal chest x-ray. The bronchi walls are very thin, they have air inside of them, and they are also surrounded by air, so you should not have any visualization of the bronchi in a normal chest x-ray. But when you start noticing infiltrates within the regions of the bronchi and the alveolar regions, then you know there is some sort of fluid density that has infiltrated the area of the normal structures. As you can see here, the diaphragm, we divide that up into a left and right hemi-diaphragm region. Right here, kind of just divide that. This dark shadow here is a gastric bubble. It is a normal finding, and it helps us kind of use it as a landmark and help us localize where we are in the chest x-ray. The right hemidiaphragm appears higher, more superior than the left. Remember, the liver is directly within this region, so it's causing the right hemidiaphragm to be higher than the left. This is a normal finding, so if you start seeing any type of flattening here, or loss of claustrophrenic angle, or any increased fluid densities here that are pressing down in this direction, you're going to be suspicious for potential lung pathology, because it is a far cry from normal. So as I mentioned earlier, make sure you study these anatomical structures on your chest X-ray that are normal. I have a few here that are numbered and they have a legend as well. There's also this one here on our right that you can label yourself or check mark, but I highly encourage you to get familiar with these structures so that way when there is a presence of pathology or fluid densities or a abscess or cavitary lesions, or there's complete loss of cardiac borders and hemidiaphragm borders and loss of costophrenic angles, you actually know where you are and you're not lost. You're not lost in the mix because now we've and given you a chest x-ray that has a disease process on it and you're completely lost. So if you ever find yourself lost when you're evaluating a pathologic chest x-ray, remember that trust normal. Normal is absolute, but abnormal varies amongst patients with presenting conditions as well. Um, so here's a lateral view here, which also is labeled. Uh, this is the left atrium, left ventricle, pulmonary artery is right here. This is your retrosternal region here. The heart is directly behind that. Here's a right ventricle. But get familiar with PA view anatomical structures as well as lateral. Airspace pathology. So within the lungs, there's areas that should normally be filled with air, but sometimes with disease states, they are no longer presenting this way. Now, there are some terms that I want you to know. There is infiltrates. So infiltrates is basically fluid accumulation within a particular area of our anatomy. So the alveoli, these small grape-like structures that are normally filled with air, you don't see them on normal chest x-ray. But when a disease process is entered into the mix, they can be filled with blood, pus, fluid depending on disorder, and you start to visualize this. So these tend to be localized within the region and the area of where the alveoli are located. So you'll start to see fluffy patterns that are shaped round like the alveoli. They may have a dark center that's going to recognize maybe a little bit of air that's left in the alveoli, but majority of these are going to be white, corresponding with a liquid density, and they're localized much more towards the mediastinal region or within the entire lungs. Interstitial infiltrates, these are outside of the alveoli. They're in the surrounding parenchyma, interstitium of the lungs. They will present themselves as a spreading out pattern, like like a streak-like pattern throughout the entire chest X-ray and lung presentation. So this is going to be the key difference here between alveolar and interstitial. Alveolar are more localized, interstitial is more diffuse and spread out. Here's an example here of what we are looking at between normal and abnormal. You have normal X-ray. You can see the air density clearly indicated here. The pulmonary hilar vasculature here. Got your costophrenic angles is sharp. You got your right hemidiaphragm. But when we compare it to this view here, we have multiple fluffy areas here that are consistent with alveolar infiltrates. So this is a good example here of localized alveolar infiltrates. They have this round pattern here. Now this is clearly taking up a lot of the lung field. The loss of the costophrenic angle here, loss of the border between the right hemidiaphragm and the previous air density within the lungs. So these alveoli are filled with fluid, and they are causing significant compromise to the patient's ability to breathe and conduct oxygen dissociation into our soft tissue structures. So in this example here, we continue with the alveolar infiltrate. So we have our bronchi. They basically meander throughout our entire right and left lungs. They have bronchioles, which are like smaller branches, and they end up terminally at the alveoli. So you will start to see these anatomical structures much more clearly when they're filled with fluid. So when you start seeing these particular patterns, these fluffy round-like patterns that are localized to particular regions in the lungs, you're going to notice that these are alveolar infiltrates. Okay, you'll lose anytime you lose the costophrenic angles. There is an issue with fluid density, uh, basically setting up camp where it shouldn't be. So, continuing with the theme of things we should and should not be seeing, there's a particular sign called an air bronchogram sign. Okay, so we've been discussing this already. The bronchi should not be visible on a normal chest X-ray. Um, there's air within them and air around them. So when you start seeing that there is a fluid dense material in the surrounding areas of the alveoli, you'll start to notice a line here that it signifies air. Okay, so it's a dark branching marking around an area of abnormal white lung tissue. This is called the air bronchogram sign. Okay, so this dark line that you see here represents air, and the surrounding alveolar structures and branches of the bronchi are filled with a fluid density. As a result, you start seeing what's left of air density within this lung region, and it's known as an air bronchogram sign. So when you start seeing this, here it is, which is not labeled here, but here also where it is labeled. So get familiar with this air bronchogram sign. It's it's non-specific. The alveoli can be filled with any type of fluid density, depending on the pathological state of the patient, such as if they have pneumonia or they're hemorrhaging or they have pulmonary edema. So if you do find an air bronchogram sign, that means that the lesion is within the lung region. Okay, that is what this signifies here. It's not anywhere else. It's not outside of the lungs, but it's within the lungs. So this is another clear example here of the air bronchogram sign. You can see these dark regions here that basically encompass the bronchi of the lungs. So we've got these trails of air density surrounded by white fluid density. And so that is what an air bronchogram sign is. Here's another example of it as well. We have a clear line of demarcation here. We call this, as we discussed earlier, an air, which is all black, fluid, which is all white, so there's an air fluid level here. Complete loss of cardiac border, obliterated costophrenic angle here. Cardiac border is completely gone. And we have air is here, air bronchogram sign right in here. You can actually see the trachea and the carina right here as well. So these are examples of right here, alveolar infiltrates. You can see it's fluffy, it's loculated to the right area, and the rest in the base of the lungs is mostly pulmonary edema. You can see here in the left lower region, we've lost the costophrenic angle on the left side. That means that fluid is basically taking up space in that entire area and collapsing the lung eventually. So interstitial infiltrate. So basically the interstitium is the scaffolding of the lung. Basically a lattice-like network that holds all the structures up. There's different areas of division called septa within the lobes that also help to classify and differentiate the vessels and lymphatics, as well as the arterioles and bronchi. Now notice that all of these structures have very thin walls, so when fluid resides in them, they're clearly visible on a pathologic chest X-ray. So here we see, and I'll continue to do this, we have our trachea, we have our carina right here, the bronchi, we have our pulmonary vasculature within the hilum, we have our left atrium, left ventricle here, we have a costophrenic angle with the diaphragm, we have the gastric bubble here, slightly blunted costophrenic angle here, and then we have these diffuse areas of infiltrate throughout the entire lung field. These are called interstitial infiltrates. I notice a difference in appearance compared to alveolar infiltrates that have more of a round shape and a fluffy appearance. These are more like streaks, and they can mimic pulmonary vasculature as well. But this is areas that once had air and invisible in a chest x-ray, but now have fluid and are visible, and now due to the pathologic state as presented here. So here's a good one to study off of. We have normal here on our far left. Right in the middle we have alveolar opacity or alveolar infiltrates, and we have a linear interstitial pattern which is consistent with diffuse interstitial infiltrates. Okay, so these are excellent to study off of and know the difference. Remember, understand normal anatomy first, then you'll be able to grasp a great idea of what has gone awry when you introduce fluid density over areas that should normally be filled with air density. Community-acquired pneumonia. So this has different etiologies. It could be bacterial, viral, mycoplasma, or just a significant amount of fluid or pulmonary edema consolidation. They have particular patterns that we can go by that we see on chest x-ray. For example, if you have a chest x-ray that has infiltrates consistent with alveolar infiltrates that are localized and focal to a particular region, and the patient is presenting with symptoms of pneumonia such as high fever, cough, malaise, this is how you're going to be able to decipher the answer to the test questions. You use the information in the question, the vignette, to help guide you to what you may or may not be looking at on the chest x-ray. In viral presentation, usually we have diffuse interstitial infiltrates combined with the symptomatology of the patient. You will probably be able to localize the area of consolidation. In this situation here, the mycoplasma origin, that's usually similar, such as a viral, and with the consolidation, that is complete obliteration, severe, basically it's like a snowball effect or a complete snow day in the lungs, so to speak. So here's community-acquired pneumonia, an example here. We have diffuse interstitial infiltrates throughout here. We have a consolidation of pulmonary edema in the left lower lobe, loss of costophrenic angle, loss of cardiac border. Here on the lateral view, so if I localize the area of consolidation here on the PA view, which is this, and now when I look at the lateral view, I'm able to now find it on the lateral view here. Okay, here's the heart, here's a retrosternal region, this nice area here of space. But this is what I mean when I say if you understand normal, you can figure out abnormal. Because here we understand this is where the left lower lobe is on the PA view. If we go laterally, this should not be there. This should not be obscuring this area. So that is where the area of consolidation is located. Based on patient presentation as well, you'll be able to figure things out very nicely. This one is the most common area here of pneumonia is the right lower lobe. So we have some right lower lobe consolidation here. We have a loss of the right cardiac border. Remember, we have two same density regions here. The heart is filled with blood, and now in this situation, the right lower lobe is filled with fluid. So we have two same densities. Obviously, that will obliterate and obscure any borders that may be seen within there. But here's your normal pulmonary vasculature, and then here we have an air bronchogram sign. So you see how things are building up here. The more we look at these, the more we will pick up certain things, okay? So that's how I want you to approach it, find with your ABCDE method, go from there. And here's your pulmonary vasculature here. So this is a good example of how to pick up on things. Remember, have that same set pattern always, A, B, C, D, E, and it will not steer you wrong, okay? Here's another example here with the right upper lobe, a good air fluid line here. It's in the right upper lobe. We obscured the visceral pleura here. Cardiac border is obscured here, the trachea as well. So in this situation here, we have the consolidation of the pulmonary edema within the right upper lobe, and it can affect any of the lobes. Silhouette sign is kind of what I was just discussing earlier. So if you have a region on your chest x-ray that is of the same densities. For example, the heart. The heart is usually white on normal chest x-ray. Why is that? Because it is filled with blood. And the surrounding structures around the heart are black because they have air density. Now, when fluid enters a previously known area to have air density and now has fluid density, now we are basically having two adjacent anatomical structures, the lung and the heart, both containing fluid density, and that obscures the normal border and contour of these anatomical landmarks and organs. This is known as a silhouette sign. Okay, so get familiar with that terminology and the description of it here. So as we can see here, this is a right lower lobe pneumonia or consolidation here. Now the right hemidiaphragm and border is obliterated here, so there's a good silhouette sign here as well. You can still kind of see the cardiac border here, but eventually as this patient continues to demise, you may start to see loss of that cardiac border as well. Remember, we take different views here. In the lateral view, we have, in the PA view, we have the fluid consolidation here, and then we try to localize it here on the lateral view. So here is your diaphragm. Now the brighter white one is your right diaphragm, and then over here we have this little grayish area, that's your left diaphragm. That's how you're able to differentiate with these things. Here is your heart, here's your retrosternal region or substernal region. Sometimes with COPD, this area is more rounded like a barrel. And here this is completely making the spine appear white in this area as well. We'll go over that shortly. So here's more examples of the silhouette sign. In this one here we have an air fluid line here, great line of demarcation. This is your right lower lobe. We have your trachea, you have your carina, you have your hilar vasculature here, you have your aortic knob, your left atrium, left ventricle. But when I get over here, I'm unable to localize the right cardiac border. So the air fluid line is localized here. As a result of a previously known area to have air density, now it has fluid density. Two areas of the same fluid density will obscure the border and outline, so we cannot see the cardiac border here on the right. So this is an excellent example of a silhouette sign here. We go towards the lateral view. You can see that even on a lateral view, where we have the pulmonary infiltrates or consolidation, it also obscures the heart border here as well. Okay, so that's what a silhouette sign is. I'd recommend you know that. Here's another example of silhouette sign. So, we go through our motions here of A, B, C, D. We find the trachea, we find the carina. In this situation, since there's, sorry, that's a little off. That as well, sorry. But yeah, we start noticing these air fluid lines here. Here's another example of an air bronchogram sign there. Clearly demarcated air fluid line here. Blunted costophrenic angles, loss of left cardiac border is an great example of a silhouette sign. But yeah, this is how you work your way through these, and we have some diffuse infiltrates here as well, in addition to the hilar vasculature here. So if you're picking up on this, notice that I'm going through a particular pattern. Find your basic anatomical landmarks, see what's missing, see what's obscured, and know your densities between air and water, bone and metal. Spine signs. So normally when you look at a normal X-ray on the lateral view, the vertebral bodies of the spine should become darker as they approach the lower thoracic region. Okay. So when they appear lighter or white, that is not normal, it is abnormal, and that signifies the terminology we use as spine sign. So I'm going to outline here each little box here as I use the example in class during the summer with the spine. Pretend it's a bunch of cardboard boxes stacked upon each other with pillows in between, and those pillows represent the intravertebral discs. Now over time and activity and weight-bearing status, these pillows will become flatter or completely obliterated over time. So there I have highlighted the vertebral bodies. The lower thoracic region here should be darker, but it is not. So this signifies a positive spine sign. So this is consistent with areas of consolidation as this has been outlined here. We have diffuse interstitial infiltrate located here. Cardiac border is somewhat obscured there. We look at the lateral view. You can see that the lower thoracic vertebrae are darker, but part of the lower thoracic vertebrae is white, as we can see here. So this is an example of a spine sign where fluid accumulation or consolidations found within the lung tissues obscure the lower thoracic vertebral bodies from appearing as they should. They should appear black or darker, but they appear white due to the fluid accumulation in its presence. So as you can see here, there's a left lower lobe fluid consolidation, loss of cardiac borders, a loss of costophrenic angle. We have a few air bronchogram signs within here. But when we look at the lateral view, this area of fluid density is now localized to here, where it's making the lower thoracic vertebra appear white. Now, as an example here of a positive spine sign. Look at this image here. This is a right lower lobe fluid consolidation. You can see that the costophrenic angle is now blunted with a small area of air density in the middle. The right hemidiaphragm border is obliterated here, so that's a good silhouette sign there. Then we find your trachea, your carina. We'll get the lateral view. This fluid density here, we're now able to see it here, and it is obscuring the lower thoracic vertebra, making it appear white when it should appear dark. So pneumonias, there's different types of interstitial. Now, most of these are caused by particular viruses or presentation of the patient. Pneumocystis is found most commonly in immunocompromised patients. Uh, and in some situations where interstitial and diffuse infiltrates are seen on chest X-ray, which are both symmetric, they're usually caused by a term we use, and you'll learn this in pulmonology, atypical pneumonias, and these are the three most common etiology of this: mycoplasma, bacterium, viruses, or pneumocystis jirovecii. So if anytime you see interstitial pneumonia, this guy here, mycoplasma bacterium, is at fault. So notice it's in the alleged color of red, mycoplasma infection. So if that were to show up as a question or anything else, you'll know the answer to that. So we have interstitial, diffuse interstitial pneumonia here, located around here. So this is etiology of mycoplasma bacterium. So immunocompromised patients, you'll notice, we have the trachea here. Now we're able to fully see. This is an excellent air bronchogram sign right here. But now we have all this patchy, diffuse bilateral, the term they use here, reticular condyle interstitial infiltrate. So if you see anything like this, you're going to associate that with an immunocompromised patient, and the common bacteria is a PJP, a pneumocystis jirovecii, but these are like tiny cysts that have accumulated fluid along the entire interstitium of the lungs. So this is most commonly seen in immunocompromised patients, but just correlate this finding with this particular disorder. Aspiration pneumonia, so we discuss this quite often in class. Basically, gastric contents should remain in the gastric region, not in your pulmonary region. So if there are situations where a patient could have a seizure, they lose involuntary control, and they could aspirate gastric contents into their lungs. They could be have a stroke, which can lead to loss of autonomic function, particularly with swallowing, as I mentioned in class, which could lead to gastric contents leaking out into the lung regions. Drowning as well, that's going to basically cause fluid accumulation within the lung regions as well. CPR can also cause this to occur, as placement of your hands is essential. Gastric contents do leak out into the bronchial tree when it is being performed. So this is important here. So if you're going to get an initial chest X-ray at first, and then 12 hours later, you're going to get a repeat chest X-ray and compare the two to see how the aspiration pneumonia is progressing, whether it's getting worse or it's subsiding. So in particular, the type of infiltrate that aspiration pneumonia shows is an alveolar type infiltrate, which is consistent with all other types of bacterial pneumonia. Aspiration pneumonia, here's a good example of alveolar infiltrates. So most of the gastric contents have entered the left lung field, causing alveolar infiltrates to be appearing on the chest X-ray. I mentioned this as well with patients that don't comply with the MPU after midnight, the night before their surgery. If they eat something after midnight or within a certain time frame of their surgery, the risk of aspiration pneumonia is very high. As I mentioned, surgeries have been canceled for small things such as a Tic Tac or any other type of breath mint, because the chances of aspiration pneumonia are increased when you don't follow protocols such as MPU after midnight. Tuberculosis here. So remember I mentioned in class that you have to be fitted for a particular tuberculosis mask. These are tiny microscopic droplets that enter through any type of mask or or potential filter that could be used as a barrier. Um, so the bacterium that is associated with tuberculosis is called Mycobacterium tuberculosis. Um, but we have here findings that are in chest X-ray. We have cavitary lesions. So as tuberculosis basically spreads within our lungs, our body starts to heal it and leads to fibrosis and scarring. Calcifications are found, which may create like an adhesion to the structures in the hilum, as you can see here, and they start to pull towards the affected side. Okay, so anything that's going to create scarring and calcification, fibrosis, is going to basically, scar tissue basically likes to wrap around certain structures and keep it nice and close. So this is why it's pulling it towards the side of the affected area. We do see these cavitary lesions as well with tuberculosis. Basically, what you see here is thick white soft tissue density in the shape of a ring, and in the center has a dark air density center. All right, so these are partially filled with fluid, creates an air fluid line within the diameter of the cavitary lesion. So remember I mentioned gravity, so as you can see here, the bottom portion of the cavitary lesion has a white border and a central dark border. This is consistent with an air fluid level, which signifies that both these processes are found in this particular chest X-ray. So etiology of the cavitary lesion could be from tuberculosis nodules or complexes that we discussed in the course, abscesses that are filled with purulence and other substances, and fungal pneumonia, as well as tumors. So anytime you see any type of these cavitary lesions and the patient's presenting with symptoms of tuberculosis, that's going to be your clear shot answer to the question. Here's a more detailed image with a CT scan, as we can see them here as well. Lung abscess. So same process here. We have a air in the center with a gravitational loculated fluid line here in the surrounding structure. So this is what one actually looks like on a cadaver. So an abscess is basically making its way within the parenchyma interstitial tissues of the lung and setting up camp and creating a cavitary lesion filled with pus, and it will basically obliterate the normal structures within it. And when you get a chest X-ray, this is what it'll look like. Okay, so if you see this associated with a lung abscess, we discussed the metastatic disease, particularly lung cancer has a strong affinity to metastasize to bone. Surrounding bony structures in the lung are your sternum, manubrium, clavicles, and vertebral body and thoracic ribs. So these are multiple nodules throughout the entire lung region. Sorry, I'm not very good at this. I don't have my mouse, but yeah, so we have these multiple nodules. These are consistent with metastatic lung cancer. Obviously, when you see these, you're going to get further testing, such as a CT scan, and then you're going to go to get a biopsy to have a definitive diagnosis. But this is what it would look like on chest X-ray. This is your first step in helping this patient out. This patient in particular has them on both lung fields throughout. These are multiple nodules consistent with metastatic disease. So if you see this on a chest X-ray, one of your differentials will be metastatic cancer, particularly if you understand which particular cancers metastasize to bone. Bronchiectasis. So as we continue to have processes in our airways that require our immune system to help out, such as leukocytosis, phagocytosis, all these immune responses that occur as a result of bacterium or viruses that are causing havoc within our bronchial tubes. The resulting aftermath is a thickened area of bronchial wall. Um, that is due to the amount of metabolic healing products that occur after your leukocytes and bacteria or viruses do battle. This can be diffuse or focal, but this can happen over time. Chronic infection or chronic inflammatory response, as seen in COPD, emphysema, and asthma in particular, can also cause damage to those cartilaginous rings that are found within the trachea. And unfortunately, once those get damaged, they are irreversibly uh, damaged. They can't be fixed after that. So this is just the respect you have to have for bacteria or viruses, how they can destroy our normal structures and cause us a great demise as far as our livelihood. This is a good example here of a thickened, dilated airway consistent with bronchiectasis. So if you see this, you probably have differentials such as a chronic lung disease such as COPD, emphysema, or asthma, or a disease state that's going to cause thickened bronchial or bronchial tubes. But yeah, same thing here. We localize the area of consolidation. So this normally is filled with air, but it's not. So now we have this thickened, dilated airway here, consistent with bronchiectasis. We're going to go now towards the soft tissue lateral neck X-ray. On your left, we have labeled areas of normal structures here. We have the pharynx, so the epiglottis should be of this normal size, but when we have epiglottitis, which is an inflammatory condition that affects the epiglottis and causes excessive drooling to occur. The patient is usually in the pediatric range of age 3 to 6. They have a classic tripod position where the patient has both his hands on his knees and he's slumped over because the amount of drool is just accumulating in their mouth and excessive, and it has to basically leak out. So same thing here as we just discussed in class. You're going to see turbulence with your airway because it's now compromised. It's thinner. You have this bottlenose effect occurring here. It will cause an increased amount of salivation to occur and drooling. But this particular finding here is consistent with epiglottitis, um, which, if not treated urgently, can eventually swell up to the point where it completely blocks that airway from doing its function. So pleural effusion. So we have the visceral and parietal pleura surrounding the lung region. This is a lateral decubitus film. So we'll notice here that if we were to look at the PA view, probably this entire region here would be consolidated with fluid. But we lay them down to our side, the fluid will tend to even out and create this region here of the air fluid line as well. So here's a schematic here of pleural effusion. So as I mentioned in class, the space between the visceral and pleural is very small. Look how large it's getting there. So it's going to basically press and cause more pressure on the lung and basically cause it to collapse eventually. Okay, so when you start seeing pleural space occupying lesions such as high fluid density as seen here, you're going to consistently have findings that are focused on pleural effusion. So here is one as well, another pleural effusion. You can see here in the lateral decubitus view, the fluid encompasses this entire lung field here with this air fluid line. Empyema, so this is basically, instead of fluid, there's pus in the pleural space. It has similar presentation like a pleural effusion, but when we place the patient in that lateral decubitus view to get that film, the pus will not move as freely. It'll kind of coalesce and move very slowly and sludge-like because of its viscosity. So this is that is the importance of the lateral decubitus view. It will help us differentiate between a empyema or a pleural effusion that's mainly consists of fluid. So you know, bacteria viruses can lead to an empyema. Sometimes if we have a cervical site infection or sterility is breached, we can lead that to occur in the lung parenchyma as well as the pleural space between the lungs. But we need to obviously look at this condition further, specifically if we have empyema in our differential. A CT scan will be better has a better technology to localize and give you a 3D image of the empyema. So that will be a next step. Then we get interventional radiology consulted, and they will do either a fluoroscopic guided needle aspiration of the empyema. So here's what one looks like here. So we have this entire area of fluid consolidation. It looks at pleural effusion with thickened material. So here is a view of it as well. Cardiomegaly. Now I discussed the many etiologies of cardiomegaly. It could be due to the fact that we call it dilated cardiomyopathy, where the cardiac muscle is becoming very weak and is unable to basically pump the blood into systemic circulation, so it becomes more flaccid and starts to spread out, encompassing the entire area of the mediastinum. In addition, there's hypertrophic cardiomyopathy, which is a congenital disease where the heart muscle is rather large and the ventricular chamber is rather small, so they only can carry a small amount of blood to send onto systemic circulation. Congestive heart failure, these changes are progressive. I will get familiar with the different mild, moderate, or severe presentations of congestive heart failure. Here's an excellent schematic here of the heart labeled. This is a great one to use as you study the chest x-rays to get familiar with both the PA and APUs. Pericardial effusion, so you'll notice a kind of a creaky rope bridge type of presentation when you apply a stethoscope to the patient. Enlargement of the heart, it will look like a huge water bag on chest x-ray. Here's a good example of one. You can see the outline of the pericardium. So this is what a pericardial effusion looks like on chest x-ray. Hopefully this helped you have a clear understanding or better understanding of how to approach chest x-rays and some of the disease process we have. Remember, always go to your basics as far as your anatomical landmarks are concerned, and good luck on the test, and we'll talk soon. Thank you.